Yes. Um, my talk will be dealing with the tube-guided decompression for lumbar and cervical problems. Actually, the previous two speakers have already mentioned about the tube-guided decompressions. So I consider Dr. Kim's endoscopic fusion is also a tube-guided surgery. Am I right, Kim? Yeah, okay. If you look at the types of minimally invasive discectomies, there are microdiscectomy, transformal endoscopic discectomy, interlaminar endoscopic discectomy, and microendoscopic discectomy, and really endoscopic surgery. I have mentioned that the first introducer of that tube-guided surgery is Foley and Smith in 1960s. They have mentioned that it for the first time in 1996, and their first publication was 1998. They have published 100 cases, and the system they have used was called metric system, metronic system. After a while, since most neurosurgeons were familiar with using operating microscope system, they modified it in the United States and working through tubes in variable lengths and diameters using microscope instead of endoscope. And so then they call it inside tubular microdiscectomy or MET system, microendoscopic discectomy, they call it. What was the difference between conventional microdiscectomy and tube-guided surgery was you were respecting the muscles more, and by dilatation of the muscles, you don't injure the muscles too much. You can see the differences between two techniques. So if it's with endoscope, they call it MED. If it's microscope, they call it MD. So these are small terminological confusions, actually. But the main advantage of that technique is the table-mounted part, which fixate the tube in different angulations, so that it allows you to see the target place in different angles. As I said before, endoscope or microscope is possible to make it. And the main parts of the system are the optic parts, introducers, instruments, and the monitor. But if you look at the instrument set, they are almost the same as you are using in the microdiscectomy. It's better to have them black and non-glare ceramic coated instruments, so then you are more comfortable under the microscope light. This is the flexible arm and table mounted part. These are the dilators, and this is the tube. I will not give you much details about it. The patient position is same. If you are working on the side of the patient, it's better to be on the pathological part, and the fluoroscopy and video monitor must be on the opposite side. This is what I was doing at the beginning. Guide wire placement, then dilatations, and then placing a work channel. It may be 14 to 16 millimeter diameter tube in case of disc herniations. But if it is spinal stenosis, 16 or 18 millimeters are more comfortable. In case if you are doing a transforaminal lumbar interbody fusion, you can switch to 18 to 20 millimeters diameter tube. These are the sequences. You can also open the inferior lamina and take the ligament, and you can see the dura, and you can puncture the annulus, and you can remove the disc herniation. Flexible arm can be angulated, so that you can, with one incision, you can approach 2 levels. For instance, with one incision, L4-5 and L5-S1 levels, you can look. This is with endoscope setup. And yes, and this is the closing. As I mentioned in the morning session, there are mainly matrix tube, easy-go system, and the Stenosis system from Storz. This is one of the cases, a 55-year-old male with L5-S1 inferior migrated disc herniation. This is one of my videos. We had a discussion in the morning whether we have to enter this space. If the fragment is making the main compression, you can just remove the fragment or sequester. So then a sequestrectomy may be sufficient, and after removing only the sequester, I'm making the bleeding control and closing the wound. You can see that by removing the tube, the muscles reapproximate there, and then we close stitches. Yes, sorry. You can also approach the far lateral disc herniations with the same technique. You can make 4 or 5 centimeters from the midline lateral incision, and then angulate your tube like you see here. This is one of the far lateral disc herniation at L3-4 level. Here you can see. We are opening the intertransverse ligament. After identifying the nerve root, some retraction of the nerve root and incision of the lateral part of the disc. Yes, this is the herniated part, irrigation of the space and closing the, yes. I have mentioned the indications of transforaminal endoscopy may be somewhat less than interlaminar endoscopy. I will tell something about lumbar spine stenosis. In the past, we were doing too much total laminectomies, so then we were damaging the muscles and then interspinous ligaments and making a defect of the lamina. Then we started doing fenestrations on both sides of the spinous processes. So then we were trying to preserve the spinous process and interspinous ligaments. This is a case of AP view that the fenestrations on both sides have been nicely done. Then the trend has started to look from unilateral side and to make bilateral decompression. At that point, you can tilt the table on the side to see the other side better. So this approach will aim to protect the ligaments, facet, and avoid instability. This is the, we then switched from microsurgery to tube-guided surgery and use this technique. This is some examples. Actually, I think, yes. This is a very narrow canal, then it was opened by this technique only. This is one of my cases, two levels. I have done unilateral approach and bilateral decompression. This is post-operative films. You can even do 4 levels. This is one case with 78 years old male. He was also in anti-flexion posture and neurogenic claudication. It was L1, 2, 3, 4, 2, 3, 3, 4, and 4, 5. Very severe narrowing. And these are the post-operative films. There's some fluid here on one side. This is, on the left is preoperative, on the right is postoperative films, you can see. This is the post-op image of the patient, and then when he came to follow-up visit, he was free of symptoms. So tube-guided, instead of tube-guided surgery, water irrigation system may be used for interlaminar endoscopy, but the surgeons doing this technique are mostly recommending to start with transforaminal endoscopy, then switch to this technique. Otherwise, you can get more dural tears and nerve root damages. I have mentioned in the morning. These are some images from interlaminar endoscopy. And you can also use some drills. But I have said stenosis drilling is harder. It has a steep learning curve, and baseline instruments are expensive. Probably these, I don't know the exact price, but the high-speed drills for endoscope must also be very costly. I will tell something about the decision making for lumbar spinal stenosis, whether we need to do just decompression or decompression plus fusion. In general saying, our decision should be affected more with clinical symptoms than radiology. No good correlation between radiology and symptoms, I must mention here. And this is my algorithm scheme. If the patient has neurogenic claudication without any back pain, so decompression alone is mostly justified. But we must consider to avoid iatrogenic instability and use MIS techniques. If the patient has additional back pain, but no instability signs, we can try for back pain, we can try facet injections, sacroiliac joint injections, brace and exercises. If there are significant radiological instability, we can offer the patient decompression and fusion surgery. If the patient has no benefit from conservative measures and injections, so then we can also try to decompression and fusion. So this is the general philosophy of when and how to make a fusion surgery in lumbar spine stenosis. In conclusion, saying unilateral approach and bilateral decompression is currently most popular surgery, but its value is not validated yet. MIS techniques for spinal stenosis have significant advantages. What about application of tube-guided surgery in cervical disc herniation? We can apply it for cervical microendoscopic discectomy. This is the patient's position. I do. This is the C-arm. And again, placing dilatation tubes and the working channel there. We can look at the region the same manner. This is the root. You can see on the axilla of the root mostly there is a small herniation. Just removing this without trying to enter the disc space is enough. These are some photographs from my patients. This is the incision line. Another patient with the same. Yes. Again, here is the point we were removing the disc. This is also a safe, quick, and easy technique. Patient positioning is important. Mayfield head holder and slight head flexion is okay. Posterior keyhole laminotomy and foraminotomy with very small medial facetectomy. Root is identified in a 5 mm section. Fragment is removed from axilla. Entry into the disc space should better be avoided. This is before 2015. It was my series. We had 2 dural laceration in lumbar spine, no dural laceration in the cervical spine, and no root injury and no infection. We had no infection at all since now. In general saying, it's an ambulatory surgery, short hospital stay, less tissue damage, no superior dissection, and smaller incisions are the advantages of this technique. But the fact is that endoscopic microdiscectomy is an effective and safe choice, but the outcomes are not superior to the microdiscectomy in terms of clinical results. And however, infection rate is less. I have mentioned in my morning session. Tube-guided surgery, discectomy may be applied in all forms of herniation and spinal stenosis. Small modification of conventional instruments are okay. Baseline equipments are inexpensive, and the learning time is quite shorter than full endoscopic or water irrigation endoscopic techniques. I thank you for listening to me. Finished.
Thanks a lot, Professor Zileli, for the very illustrated and very interesting topic. I think we open a panel discussion. All of you are ready and here. Professor Kim, are you here? Professor Kim, are you here? Professor Kim, I'm seeing you.
Sorry. Yes, I'm here.
Yes, okay, you are here. Okay. Dr. Thomas, I'm seeing you. Ready? Yes? Dr. Nadir is not here or what? No, Dr. Nadir, are you here? Dr. Nadir? Dr. Abdullah, are you here, Dr. Abdullah? Dr. Abdullah?
Yes, available. Yes.
Yes, okay. Dr. Abdul Bar?
Yes.
Okay. I will send the first question for all of you. This question is, can we do a repair of the annulus fibrosus after removal of the herniated disc sequestrum to prevent a recurrence? Dr. Kim, please.
Yes. Yes, before time, maybe in the open surgery, they are similar technique already introduced, and they give some decreasing some recurrence. But actually, I don't agree to decreasing the recurrence. Maybe suture is not also easy, and still there is very weak point because of that. You need more strong study. I don't need agree completely.
And if you want to do a repair, how do you do the repair?
Actually, the annulus already weak state, not a tear state. If that tear state suture will be make some preventing and make some strong, but that already like a balloon, very weak state. Because of that, the suture will not give very strong force.
Yeah, I can give you an answer. Actually,
Yeah, yes, welcome.
You probably have heard about the barricade. Barricade is the German study. German and Austrian surgeons are doing a very long-term study. They have also published 5 years results. They say the barricade is somewhat preventing the recurrence. However, it's not a very easy technique. Besides, they also select patients, the high-risk patients they place. I mean, for instance, the patients in the younger ages, the patients with the disc height preservation, there are some criteria to choose it. It is a device that you implant inside the end plate so that it covers the rupture site of the ligament. But there was some participants asked us about the what do you do to prevent recurrences? Do you remove all the disc? Do you do some other measures to prevent it? I believe prevention of the recurrence is inevitable. It's not possible. It's a kind of instability occurring inside the motion segment. So I don't think we have to try to prevent recurrences. We must try not to leave any compressing part inside. That's all we can do. But if it is a free fragment, if the free fragment is causing most of the compression, you can just remove it and leave other disc tissue. Don't even enter inside the disc. This is my idea. This is my recommendation.
Very nice idea and very crucial advice. Dr. Abdullah, what's your opinion, Dr. Abdullah? Dr. Abdullah?
Hello, assalamu alaikum.
Yes, welcome.
Okay, yes, concerning, well, I had the idea always to make a sufficient evacuation of all the soft material. I mean, the nucleus pulposus for me should be totally as much as possible removed. But in endoscopic surgery, I don't have that much experience. I was going to say the same thing like Professor Zileli concerning this Paracuda plug, which is done by, I think, Medtronic company, if I'm not mistaken. But I don't think that this can be done through the transforaminal approach. It only can be done maybe through the translaminar approach. I have no much experience in it yet also. I tried it for some cases in the microdiscectomies and the tubular discectomies. That's all. But still, my opinion is evacuate as much as you can from the disc space, from the soft material, which can be, according to your opinion, can be dislodged later on upon mobility, especially if there is no fixation.